Hello, my name is Tia Campbell, and today I'll be speaking to you about post-traumatic stress disorder, or PTSD. PTSD is a psychiatric disorder that can occur in people who have experienced or witnessed a traumatic event. This may include, but is not limited to, natural disaster, terrorism, war, personal or sexual assault, and serious accidents. Between 5 to 10% of people will experience PTSD at one time in their lives, with women being twice as likely to report having PTSD than men. There are various criteria for diagnosing PTSD in the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, or DSM-5. Because of this, I will explain each of them briefly as I show further information here on the screen. Please feel free to pause this video at any time to read in depth the criteria for PTSD. The first criterion that must be met is criterion A, which is that you were exposed to one or more events that involve death or threatened death, actual or threatened serious injury, or threatened sexual violence. In addition, these events were experienced in one or more ways that are currently shown on the screen. Next, criterion B is that you experienced at least one of the intrusive symptoms associated with the traumatic event that are shown here. Criterion C is frequent avoidance of reminders associated with the traumatic event, as demonstrated by one of the items currently shown here on the screen. Criterion D is the negative changes in thoughts and mood that occurred or worsened following the experience of the traumatic event. Two of the items shown here on the screen must be met. Criterion E is changes in arousal that started or worsened following the experience of the traumatic event, as shown currently on the screen, and two of these items must be met. Criterion F is that the aforementioned symptoms last for more than 1 month. Criterion G is that the symptoms bring considerable distress and/or interfere greatly with a number of different aspects of your life. And finally, criterion H is that the symptoms are not due to a medical condition or some form of substance use. Here on the screen is a brief summary of the criteria that must be met in order to be diagnosed with PTSD. PTSD can occur after a person is exposed to a traumatic event. When we are exposed to a stressful or traumatic situation, the body's fight or flight response kicks in. And normally, when a stressor goes away and is no longer present, the body adapts and our anxiety is reduced. However, in the development of PTSD, the person's body fails to adapt to the traumatic event, and as such, the fight or flight response remains in place. It is important to note here that not everyone who experiences trauma will develop PTSD. In fact, it is estimated that about 25% of people who are exposed to traumatic events will develop PTSD. So why is this? Well, the research isn't clear about why some people develop PTSD and others do not, but it is probably caused by a complex mix of certain risk factors which can be categorized in two ways. The first way is currently shown here on the screen, and it consists of pre-traumatic experiences such as previous trauma, peri-traumatic, which include the severity and duration of the trauma, and post-traumatic experiences, which include a lack of social support after the event. The second way that risk factors can be categorized, shown here on the screen, is biological. So, for example, inherited mental health risks, such as a family history of anxiety and depression, psychological, such as low self-esteem, and social, for example, sad childhood experiences. Some preventative factors that can help mitigate the risk of developing PTSD or even help improve treatment outcomes, and they include building resilience, improving social and family support, and help-seeking behaviours. The assessment and diagnosis of PTSD is based on the criteria in the DSM-5. As is best practice, a clinician should always first undertake an initial interview and mental status examination. This is especially important here because people with PTSD will not necessarily express concern about a traumatic experience in the first instance. Instead, they may present with a range of problems including mood disorders, relationship problems, poor sleep, and physical health complaints. If a traumatic experience is suspected, the clinician may utilize a traumatic events checklist. One such checklist is the Life Events Checklist, and it's known as the LEC5. This is a quick self-report measure and screens for potentially traumatic events. If the person endorses any events on the checklist, then it is recommended that a PTSD screening tool be administered. One type of screening tool is a structured interview, and an example of this is the clinician-administered PTSD scale for DSM-5, or CAPS-5. This is a 30-item structured interview with standardized questions and probes, where the client rates the intensity and frequency of 20 DSM-5 PTSD symptoms. This takes approximately 45 to 60 minutes to complete, and it's used to make a current diagnosis of PTSD. Some other types of structured interviews are shown here on the screen, and most of them have been updated to correspond to the most recent version of the DSM. One can also complete self-report measures to assess subjective distress or to determine a preliminary diagnosis of PTSD. And one such measure is the PTSD checklist for the DSM-5, known as the PCL-5, and it's mostly used for screening people for PTSD. I am now showing here on the screen various other self-report measures that are recommended by the APA. Each instrument that I have mentioned and that is shown here has evidence of reliability and validity. Additionally, comorbidity is common in PTSD, with many clients presenting with another disorder such as depression, substance use, or anxiety. It is for this reason that assessment should go beyond just PTSD and cover a broad range of potential mental health problems and their implications for treatment. On that note, let's discuss treatment options based on evidence-based psychological practice. There are a number of different treatment options available for people suffering with PTSD. Trauma-focused cognitive behavioural therapy, or CBT, is the gold standard of treatment for PTSD. One type of CBT is known as prolonged exposure therapy, and this consists of two aspects, both of which aim to teach the client that the trauma-related memories and cues are not dangerous and do not need to be avoided. The first aspect involves the client confronting the traumatic memory in a safe and controlled environment through imagined exposure, imaginal rescripting, and virtual reality. The client describes the event in detail and in the present tense with guidance from the therapist, and together they both discuss and process the emotion raised by the imaginal exposure. The second aspect of prolonged exposure therapy involves confronting the trauma-related avoided situations and activities through in vivo or live exposure. They can do this through use of a fear hierarchy of exposure situations, where the client would confront each item until they no longer experienced anxiety or could cope with the associated emotion that is brought about. And the goal of this is to reduce or extinguish the conditioned emotional responses to the trauma-related cues. Typically, in this type of therapy, the client's symptoms are exacerbated before they improve, and doing this does increase the risk of relapse and even dropout. Prolonged exposure therapy is typically provided over a period of about 3 months with weekly individual sessions. The sessions begin with the therapist providing an overview of the treatment and understanding the client's past experiences. They will then continue with psychoeducation and will generally teach a client a breathing technique in order to manage their anxiety. Generally, after the assessment and the initial session, the exposure begins, and this can be very anxiety-provoking for the client. This therapy is improved when also combined with cognitive processing therapy, or CPT. Another popular type of therapy is eye movement desensitization reprocessing therapy, or EMDR. And in addition, other strategies, as shown here on the screen, may complement forms of evidence-based therapy. Beyond psychological treatment, there are also pharmacological treatment options that are available, and medications include SSRIs and SNRIs. But research suggests that most often, a combination of treatment works best. There are various ways that a clinician can measure the outcomes of treatment for clients with PTSD. One of these is the PCL-5, which I discussed earlier, and this should be given at the start and the end of treatment, but can also be administered throughout treatment. Another example is the CAPS-5, which I also discussed earlier, and this should be given at the start and the end of treatment if time permits. The Outcome Questionnaire 45 can also be used as a repeated measure throughout treatment. Another way to measure treatment outcomes is by asking the client to complete a self-monitoring log or a diary of intrusive thoughts and responses. I also mentioned earlier about comorbidities such as depression and anxiety. It is important to undertake relevant measures of change in these disorders too. If measures of treatment outcomes show that the current treatment is not effective, there are various options moving forward. For example, the clinician can change the type of therapies being used, they can check the diagnosis, they can refer the client on for medication or seek supervision support or even intensify the treatment. It is so important to remember that everyone experiences trauma differently. An event which is traumatizing for one person may not be too distressing for another. Everyone has a different capacity for trauma, which is informed by a combination of risk factors including neurobiology, past experiences, and genetics. Fortunately, though, there are many treatment options available for people suffering with PTSD that have yielded great success. Thank you so much for listening.